we've got to make sure that we get our messages to our policymakers about the importance for continuing to fund this important work. So we're going to have 3 panels, and I'm going to introduce the first panel just by their name and affiliation. You have all of their bios that you can read and see how impressive everybody is on these topics. Each one will come up individually. They'll give their presentations. We're going to be really strict, trying to keep it as tight as possible so that we've got time at the end for some conversation and questions. So this panel of discussion is the landscape of neglected diseases in Texas and Mesoamerica. The neglected parasitic diseases. Our 3 panelists. First, Peter Melby, who's the Director of Center for Tropical Diseases at UTMB. And Sue Montgomery, the Public Health Service, CDC. And Jesus Valenzuela, the Chief of the Medical Vector Molecular Biology Section at NIH. So we've got the local and the national agency. So first, we'll start with Peter. Thank you.
Leishmaniasis is a vector-borne zoonotic disease. The typical transmission cycle involves the sandfly insect vector and an animal reservoir. In the case of visceral disease, the animal reservoir in Latin America, throughout the Americas, is the domestic dog. And then for cutaneous disease, the reservoir varies, but it's typically a forest or kind of desert rodent. Shown in the picture here, not sure where down in your lower left is Neotoma micropus, which is the southern plains wood rat, which is the documented reservoir of Leishmania mexicana here in Texas. People get infected when a susceptible population comes in contact with this zoonotic transmission cycle. Shown there is a small town in Colombia. It could be Honduras. It could be a small ranching area in south central Texas. It's estimated that about 10 million people have leishmaniasis. However, we know that this is a significant underestimate. I was just in this south central mountains of Honduras last week, in an area where it's only accessible by a 4-wheel drive vehicle. And we examined about 200 kids at a couple of schools, and about 15% had lesions that were consistent with leishmaniasis. Certainly the majority of kids in that setting are not going to get reported, so it's clearly an underestimate. Historically, we've thought of leishmaniasis as a disease that was imported. You can see some examples of clinical cases. It's typically a non-healing ulcer on an exposed part of the body, the face, arm, lower extremities. And shown in the middle is the map, nice study by Barbara Herwalt at CDC that showed where cases that occur in U.S. travelers come from. And you can see that about 40% of cases that are imported into the U.S. in U.S. travelers come from Central America. However, over the last several decades, it's been very clear that, in fact, transmission of leishmaniasis does occur in Texas and other parts of the United States. Shown here are some cutaneous lesions caused by Leishmania mexicana in people from Texas who had no history of travel. It's typically a nodular, non-ulcerative lesion. It can be quite extensive, as you can see. And again, the reservoir host is the southern plains wood rat, the genus Neotoma. And the transmission cycle actually was worked out by Chad McHugh, who's an entomologist in San Antonio, and Sarah Kerr, who's a field biologist, basically working on their weekends over a number of years, and really did some outstanding work to define transmission within South Texas. Shown here on your left is a map, and the black dots are cases that we reported in a review back in the mid-90s, that with the first case being in the early 1900s, and it was thought to be fairly localized to south central Texas. However, recently other cases have been reported up in the Dallas-Fort Worth area. There have been cases reported as far north as Oklahoma without any travel to a tropical area. Shown on the right is a map that again shows the human cases in pink there in the Dallas-Fort Worth area, but also cases that have been identified in cats. So both the domestic dog and the domestic cat can carry this disease, and it's unclear what their role is in transmission in the U.S. and elsewhere. Shown here are maps that show the vector, possible vectors and the reservoirs of cutaneous leishmaniasis in the U.S. On the upper panel, you can see dots related to Leutzomia anthophora and Diabolica, and I think Jesus is going to talk more about the vector aspects of the disease. But largely those dots represent where an entomologist works. So we really don't know what the spread of these insect vectors is. And then you can see that there are a number of Neotoma species that could potentially serve as reservoir hosts that are spread throughout a good part of the U.S. A very challenging and provocative review related to climate change in leishmaniasis was published by a team of Mexican investigators. And I put on here a couple of their conclusions because there's really something to think about. They say that even with the most conservative assumptions, the distributions of both vector and reservoir species expands northwards, potentially reaching as far as southern Canada to the east. And then again, even in the most optimistic scenario, we found that twice as many individuals could be exposed to leishmaniasis in North America in 2080 compared to today. So there's a very strong likelihood that this disease is going to continue to spread and become more of an issue in the U.S. Well, what about visceral disease? It's the more serious form of the disease. Shown here are some children. They have systemic infection, involves the liver, spleen, and bone marrow. It's ultimately a fatal infection if it's not treated. And again, the domestic dog is the reservoir host within the Americas. And you can see on the map the distribution, good part of Brazil and other parts of South America, and then up through Central America and Mexico. And you don't see the U.S. on that map. However, over the last 5 to 10 years, it's been recognized that in fact Leishmania infantum, which is the cause of visceral leishmaniasis, has been found to be highly prevalent in some populations of dogs in the U.S. So initially started as in a foxhound kennel in New York, and shown on the map there on the lower left, you can see the distribution of areas that have reported disease in the canine population, and this is largely in the foxhound population. And what's most concerning is the pyramid on the right, where the map on the left shows only those with clinical disease, which we know makes up only a small portion of the infected animals. And it's likely, or at least possible, that transmission can occur in the absence of disease. So shown on the pyramid there's a much larger proportion of dogs that are seropositive or have evidence of infection by nucleic acid detection, and those dogs may be involved in transmission. It's thought within the kennels transmission is probably occurs congenitally through crossing the placenta. However, the role of sandflies in the transmission and the risk to humans really has not been clearly studied. So I'll just finish with a couple of points about where we need to go to address the emergence of leishmaniasis in the Americas. Certainly we need systematic field-based epidemiology. The not so glamorous, not so newsworthy shoe leather studies that will define the role of the insect vector in the reservoirs, determine risk factors, and evaluate the potential and the real economic impact in the Americas. We need new approaches to vector control strategies. We need discovery and development of new drugs for the treatment of leishmaniasis. The drug that's used in the U.S. has been used for almost 70 years, and it's a toxic heavy metal drug that has to be given by intramuscular or intravenous route. And we need discovery and development of vaccines for prevention of leishmaniasis in both humans and in the canine reservoir. Thank you.
Thanks. We're going to change gears a little bit here, and I'm going to talk about Chagas disease, and then the next presentation will take you back to leash again. Chagas disease is caused by a protozoan parasite, Trypanosoma cruzi. This parasite is only found in the Americas. It affects more than 8 million people in Mexico and areas of Central and South America. It's a zoonotic disease, so like leishmaniasis, there are important animal reservoirs that maintain the parasite even if human infection is not present. And control efforts in Latin America have largely concentrated on controlling vector-borne transmission. So the control programs in Latin America involve spraying of homes that are infested and preventing the reinfestation of those homes by repeated spraying. The triatomine species in those areas of Latin America, so in Central, South America, and most of the Mexican areas as well, are adapted to living in people's homes. So they want to be in people's homes, and they have managed to establish colonization in those places. There are other important modes of transmission, including congenital and also through contaminated blood transfusion. About 20 to 30% of people who are chronically infected will go on to develop important clinical disease. Mostly it's cardiovascular, and typically it starts with arrhythmias but can progress to heart failure, stroke, sudden death. There are also gastrointestinal manifestations, more prevalent in the southern cone area of South America, and these are megasyndromes such as megaesophagus, megacolon. And there's a very important concern with reactivation disease in the immunosuppressed. So patients with HIV/AIDS, transplant recipients, transplant organ donors to immunosuppressed recipients, those are important considerations. And there are currently not such great diagnostic tests available. There is no gold standard test for this disease. So in order to diagnose Chagas disease, you have to use more than one test, tests of different formats and different antigen preps. The two treatment drugs that are available are nifurtimox and benznidazole. They are considered less effective in chronic phase, so the goal is to treat people earlier in their infections, preferably during the acute phase or even during early chronic. And both these drugs have some pretty significant side effects. They can be difficult for patients to tolerate. The good news is that nifurtimox is a donated drug, so WHO has received a drug donation from the manufacturer and a guarantee that this drug will be available as long as it is needed. The trick is that they can only provide this drug to ministries of health in countries that have a distribution program. So if the country doesn't have a way of getting the drug out to people who need it, WHO is going to try and work with them to make sure that that is the case before they give them the drug. There's a multi-center randomized control trial looking at the impact of benznidazole on patients with early cardiac manifestations. The thought is, and this has been the clinical experience of people in Latin America who've treated many patients over the years, that if you treat someone when they first develop clinical cardiovascular disease due to Chagas, they have arrhythmias, that maybe if you treat them then you can actually slow or even stop the progression to the much more severe outcomes. That trial is still ongoing, but we're anticipating that there'll be some really good data coming out of that. In the US, CDC estimates there are more than 300,000 people who are infected, and these are US immigrants. They're people who acquired their infections in their country of origin in Mexico, Central South America. We are only estimating there is no national public health surveillance for Chagas disease, and in fact, it's only reportable in 3 states, Arizona, Massachusetts, and Tennessee. And do those states make a lot of sense in terms of the epidemiology? No, but each of those states had a particular reason for making it reportable. There have been 23 cases of human vector-borne acquired infection in the US. The first case was documented in 1955. This is not new. And the triatamines, the bugs that transmit, have been identified since the 1850s. That's centuries ago, essentially. T. cruzi was first documented in 1916, and I think for those of you who know Chagas, this is a very interesting date because it was 1909, 7 years before that, that Carlos Chagas made the association between disease and the parasite in Brazil. There are only 2 documented cases of congenital transmission in the US. One, an immigrant mother who delivered an infected baby, and the other, a US-born mother who had resided in an endemic area of Latin America for 2 years, returned, had a child 7 or 8 years later, and that child, as an adult, was found to be infected when she donated blood. We think there's probably a lot more out there of congenital transmitted infections. The blood donor screening was introduced in 2007 in the US, and where there are more than 1,600 cases, confirmed cases of Chagas disease that have been identified through blood donor screening. So this map is from the American Association of Blood Banks, the AABB. They have a site that reports confirmed positive blood donors. It's a voluntary system. Blood banks may choose to report or not. So this likely is an underrepresentation of the blood donor results. But it shows where these donors are being found. So each red dot is a positive donor, and it indicates the zip code of residence for the donor. And you'll see that certain areas light up. Those are the areas where we have large immigrant populations, and especially California and Florida. And then I've pulled out the Texas map and enlarged it a little for you to see where the positive blood donors in Texas have been reported. We know, because we've been in contact with physicians caring for these patients or with the local health department, that quite a few of the blood donors in Texas actually are not immigrants and have no travel history and very likely did acquire their infections here in Texas. This is a map from a publication looking at triatamine bugs in Texas and testing them for T. cruzi infection. And in the hatch-marked counties are where the bugs were found and the bugs were infected with T. cruzi. And overall, across the entire study, 50% of the triatamines that were captured in Texas were positive for T. cruzi. And the picture just shows you the common species of triatamines, and you may recognize them from your backyard. There are a bunch of challenges in the US, and CDC is trying to address this, and some of our efforts have been more successful than others, but we're trying. Probably the first and what we consider a very significant challenge is to improve healthcare provider knowledge and awareness of this disease. Most healthcare providers just don't know it. They might remember it being mentioned during that 2-hour lecture on parasitic diseases in medical school, but typically they feel they've never seen it in their practice. Well, have they not, or are they just not aware of it? We've put together an online CME. You're all welcome to take it. It's accredited. You get CME credits for it. It's free. We have done a lot of health education activities. We're done studies to document the lack of awareness. We're just starting to chip away at this issue. Because of the concern with testing, where diagnostic testing for Chagas is very problematic, the commercial labs, a handful of them do offer testing for Chagas, but they typically only have a single assay. And if you'll remember, I told you that there is no gold standard, so we can't rely on a single assay. We really need to have positive results on 2 or more different assays with different antigen preps. CDC recognized the need for a PCR testing, a way to identify acute infection early before hemoculture or other methods might work. And we've put PCR testing in our lab. Currently, it's really the only place in the US to get that. It's appropriate for monitoring transplant recipients, for trying to pick up acute infection as early as possible and get those people treated promptly. Congenital infections is another place where we would use PCR. It was 5 minutes, just 10 seconds ago. Okay. Okay, we are trying to ensure that treatment drug is available. The 2 treatment drugs are not FDA approved. They are available at CDC under investigational protocols. There's no cost for these drugs. CDC releases to physicians without charge. As I mentioned, congenital transmission is a concern. We really need to define that risk and also come up with cost-effective strategies for screening and treating infants who are born infected. We've just started, again, to chip away at this one. We've had a small pilot study right here in Houston where mothers were being tested at delivery. Actually, cord blood is being tested, and if cord blood's not available, then we have maternal plasma to identify infected mothers. We're in the middle of data collection with that study, and I'm hoping to then expand to a larger multi-center approach on this. Reducing cardiovascular disease due to Chagas in the U.S. is very important. We really don't have a sense of how much burden there is of cardiovascular disease. We've supported a handful of small facility-based studies where patients with arrhythmias typical of Chagas have been enrolled and tested, and the prevalence in those studies has been about 14 to 20%. So it's there, and it's important, it's causing disease. But nationwide, we really don't have a sense of that. Preventing vector-borne transmission in the U.S. is a challenge. We really don't have a sense of how big or important this risk is. We've had those 23 cases since 1955. Is that the tip of an iceberg, or are we looking at a problem that isn't that important relative to our imported infections? Don't know. We have been helping at the state of Texas. When people catch triatomine bugs and contact the health department, they can send the bugs to CDC, we speciate the bug, and we also can test for T. cruzi in the triatomine. Changing gears. These are, I think what everyone would agree are some really important research and development needs worldwide. And again, this diagnostic test, I keep coming back to that because even if a physician thinks, gosh, my patient might be at risk, we need to have really good tools to diagnose the infection so that the patient can get appropriate care. So there has been some concern with the performance of different tests in detecting infection acquired in different geographic areas of Latin America, that maybe the tests that work well on southern cone infections are not working so well on North America infections. We need tests that give us results quickly, that are easy to use. A rapid test would be ideal for a lot of bedside screening, in particular in the congenital transmission risk arena. And we need something that uses a readily available sample type, so something like a drop of blood or something that you can do quickly and easily and isn't a complicated research test. The test of cure after treatment is, I think, everyone's dream test. I'm not sure how far if we're really ever going to get that, but ideally there would be a way to tell once someone's treated that they are cured. Right now, the antibody will persist. Some researchers propose that it actually goes away after a certain amount of time. How long, what tests you use, these are all undefined, and those tests are not validated. And we definitely need better treatment drugs. We need drugs that are effective without side effects and are safe and convenient for both babies and adults. The drugs that we have right now, you can only take orally. They're not FDA approved in the US. They have prolonged treatment courses of at least 60 days. They have to be taken multiple times a day. The side effect prevalence is actually quite high. About 30% of people on nifurtimox will have problems tolerating the drug. Sometimes they actually have to stop taking it, so they're not getting appropriate treatment then. And I just wanted to put these two websites up, so if you had any questions, you wanted to investigate more about Chagas disease, we actually have a lot of information on our website, links to that CME I mentioned. We have maps of where the vectors are in the US, and a lot of other information that you might find useful to share with your patients. It's translated into Spanish as well as English. And then, of course, the WHO site for the global picture as well. Thank you.
All right, I want to thank the organizers and Peter and Maria for inviting me to this talk. I feel a bit overwhelmed and shy about being with this caliber of panelists talking about these diseases that I study a lot when I was at graduate school, moved on a postdoc. And today I'm going to talk about something slightly different, about the vector, but actually what I do for research in these vectors, which is still my kids don't understand, is saliva of insects. Yeah. Then how are we using this information from global health and how this information we can translate to research here in the United States, particularly to neglected diseases. Then that's what I'm going to try to cover in 7.5 minutes. Then this is what I do. Sandflies. We work with sandflies, and sandflies, as Peter mentioned, are the vectors of Leishmania. When you hear about insects, or sandflies, or ticks, or triatoma, you think about just flying syringes or crawling syringes. They just transport the parasite from one place to another, and you get infected. But they're more than that. They're very potent incubators. If the parasite cannot develop to the infective form inside of the vector, there is no transmission, number one. Number two, when you're bitten by the bug, besides getting the parasite, you get also saliva. And saliva modifies your immune system and your hemostatic system as well. And that also helps the parasite to get established. Then what we do is study saliva. How can we study saliva to, number one, and this is some of the, I don't have the pointer, but I'm going to use this. No, oh, yeah. How can we use saliva? Oh, there you go. Thank you. Now, how to figure it out? The middle bottom. Yeah. Okay. How do we use saliva for this? Then, saliva is, there are very small number of molecules in insects. And we know that saliva, every time that you are bitten by an insect, probably mosquito, you feel there is an immune response. Some of these are antibody mediated, and some of these molecules are cellular they produce cellular immune response. We are looking for molecules that produce cellular immune response that can attack Leishmania, because that's the way that Leishmania is controlled, by cellular immune response. Simple. Well, not that simple, but that's the snapshot. Second one is markers of exposure. This is something new that we are exploring, and that many labs around the world are exploring. We know that saliva produces antibodies in our body. Then can we use these antibodies to make a risk assessment, to study the population of how many people are being bitten or are at risk of disease? Can we use these proteins? Then the answer is actually yes. Then another challenge for me, I'm a molecular biologist, biochemist, then entomologist, and start becoming a little bit of immunologist. But I need lots of help to move this forward. And what I learned is that all this idea of going into vaccine and understanding insects and public health, I really need help in different specialties. And this is one of the things that I'm learning, partnerships, groups of different institutions and specialties moving this forward. And also with these economic times, trying to get funding is much easier to do so. Just as an example of one molecule, this is a protein from the saliva. This is in a mouse model. If we inject this molecule in the mouse without adjuvant, 500 nanograms, and we challenge these animals with infected Leishmania major parasites, these animals are protected. This is the bar right here. And I don't know if you can see in the figure here, control animals that were injected with BSA lost half of the ear with this parasite after 5 weeks. The other animal were completely protected. Then this is one example that we're doing from basic research. We're moving this to the field. We're trying to do vaccine for dogs. We're trying to understand this in a human population. This is what I'm trying to go from basic to translational research. And the other part about markers of exposure, which is something that we're moving forward, is the development of this platform to identify and produce markers of exposure of sandflies and also triatomins. We already, one of the things we do, and I do very well, is actually as a molecular biologist, is to find the molecules in sandflies and any insect. And these are just a couple of publications demonstrated that yes, we can find these molecules and we can use them actually in the field. And this was actually, we published this last year in PLOS NTD in Brazil, using salivary proteins from sandflies. Just to give you an idea of this platform and how can we move this knowledge of global health to here. For example, this is the map of leishmaniasis around the world. And I put here some couple of triatoma bugs of transcriptomes we have done. Here, this is the comparative analysis of different transcriptomes around the world we have done. And we can do this rather fast, identify all the molecules. But one of the things that struck me was this, nothing here. We don't have much information there. And if you learned from the last two lectures, the two lectures before me, there's not much information about the vectors. And this is something that when I was trying to read more about before coming here, I learned what vectors are here, Antophora and Diabolica, and their potential vector. Actually, we still do not know if they are the vector for a particular Diabolica for Leucomia mexicana. And here in Chagas disease is the same. You have few vectors, but still there is no direct evidence. Then we definitely need more information about the prevalence of infection in these vectors in this area. I mean, when we're talking about just focus on this particular area. We have the capability of identifying and do the molecular characterization of vectors, but we have not done that. We have to move into this area, and we should, the seasonality of the vectors, literature for this area is very limited. We have great work, but decade old. And all actually, there are some papers from coming from last year, but if you compare the literature from this area compared to around the world, it is amazingly different. It's a disparity there. And of course, this is something that we're proposing. Human exposure to vectors or the parasite. We need that information. If we want to start defining the disease, seeing how we're going to implement a cure or studies, this is a part that we really need. And we are proposing using also these salivary proteins to start doing this assessment in addition of the parasite. And I don't know if I did 7 minutes or not. This is just to recognize the people that have helped me and my lab and other labs around the world to move this research forward. I just touching 2 things that we do in the lab, but we do many other aspects too. And I want to recognize what I have mentioned to him, Peter Hotes, which has become my recent mentor in research, moving myself from going to more molecular and trying to understand more about public health and the impact of neglected diseases and how can we ourselves contribute to this endeavor. And with this, I'll finish, and thank you very much.
All right, we've got some very rich topics here with some of these our terrific experts. So we will take some questions from the audience and hopefully stimulate some conversation. So we've got 2 individuals with microphones, and if you raise your hand, here we go, right on the side there. Say who you are and where you're from, and then your question, please.
Richard Wilson, University of Houston and the NIH WRC in emerging diseases. I wanted to ask Dr. Montgomery to tell us a little bit more about the state of the art for diagnostics for Chagas.
Is this on? Yeah, okay.
Move it closer to you.
Move it closer. Okay, is that better? The state of the art is that there are many efforts to develop better tests. One of the issues is that the laboratory strains of Trypanosoma cruzi that are used to develop tests may vary. Some of them have been in the lab for quite a long time. Does that reflect what is circulating now? So that's one issue. The other is that the individual immune response to the parasite appears to be quite variable. So there's a group at University of Georgia that's been looking at essentially generated an antigen panel using the genome of the parasite. Again, it's a particular strain of the parasite, but they think it's pretty representative. And when they've tested individual patients who are infected, they get a whole bunch of different antibody responses to each of those antigens. So in a research setting, they think they've got something, but it just doesn't translate into a clinical setting. There are efforts to look at PCR detection of parasite and use that as some kind of a way to confirm that this person is truly infected and then maybe use that after treatment. Those efforts it's a challenge because there may be something different about people who are more likely to be PCR positive before treatment and as opposed to others who don't come up PCR positive as frequently. That's the state of the art. There's a WHO effort right now looking at a series of rapid tests that various manufacturers have put together. Some of those tests are looking promising.
Thank you. I think we'll have Dean Hotez. He can take the next one.
I think it's the first time I've ever been called Dean Hotez in a public setting. My son is looking at me like, who's that? So, there was an excellent panel, and before I go there, I just want to go back to Joe McCormick's comment, because he made the comment that we really don't pay attention. Is he over there? There he is. Yeah. We don't really pay attention to disease until they hit our shores, and so I'd like to give the Hotez corollary of that, which is not, you need to take it one step further. It's not just, we just heard about 2 diseases that have hit our shores. Hitting our shores is not enough. It's hitting, it's hitting a very selected, noisy group of people that get media attention, right? Everybody in the United States has heard of Lyme disease. Nobody in the United States has heard of Chagas disease and leishmaniasis. So it's not enough to hit our shores. We need to be doing something else, because simply hitting poor populations in South Texas, hitting people of color is not enough as well. So, and with that introduction, I'd like to go into the panel discussion, which was really excellent. I really loved everyone's comments. I think it was Sue Montgomery who used the metaphor of tip of the iceberg, and I think that's a good overview of the panel, because that's where we're at right now. We're just looking at what I think may be the tip of the iceberg with respect to Chagas disease and leishmaniasis. We've heard this morning that it's widespread in dogs, widespread in other animal reservoirs, wood rats. The insect vectors are widespread, both kissing bugs and sandflies. We're hearing about maternal-child transmission. It's in the blood supply, and yet despite that, we're still at a very nascent, early, rudimentary stage of active public health surveillance. I think it was even Sue who, or maybe it was Peter who said we don't have burden assessments. Peter then said modes of transmission are minimally assessed. We have minimal local and state laboratory testing for diagnostic capability, because we don't have kits that can easily be developed and used by Quest Diagnostics or commercial labs. The available drugs that we have were developed sometime during the Jurassic era, and so that's a problem, and really nothing in place for vector control strategies. So I'll ask the panelists, and I'll add Joe as well, how do we begin those kinds of things? The sense I'm getting is we're at a tip of the iceberg phenomenon. There potentially is a lot of disease out there, but it's a problem that is truly being neglected for all the reasons I've mentioned: lack of public health surveillance, lack of transmission studies, minimal local and state laboratory capacity, drugs not being developed, vector control. How do we take Chagas and leash to the next level?
I'll make a couple comments. First is, I think we as scientists have been extraordinarily poor at getting the word out. And we're not very good at it. I speak for myself. I'm not a very good salesperson, publicist, So I think that's something that we can do, and doesn't take a lot of funding. The other issue is, one is we've kind of lost some emphasis on public health in the scientific community. It's easier to get funding if you have a very nice, neatly hypothesis-driven molecular study, and it's more difficult to do a broad-based, more descriptive epidemiology study to get funding. We need people that are better, more people that are trained in the public health arena. But I think it really boils down largely to public will and to funding. And we need to figure out ways to increase that.
I will jump in there that public will and funding is directly connected to the community that cares most about these issues. And I know that as a longtime observer and someone that greatly admires the science community, you didn't get into this line of work to go out there and talk to the media and to policymakers about why you do this. And actually, I think that can be a strength for you because you really are speaking from the heart. You don't need that kind of fast training. What you do need is just to, instead of talking in 5 paragraphs, learn how to talk in 1 paragraph. But your commitment certainly carries your message very strongly. I do have a related question for the panel is, what is the impending sequestration going to do to funding for this work that already is underfunded, under-acknowledged? Sequestration is what's looming out there for Congress to make draconian cuts to NIH, CDC, across the board, to save enormous amounts of money that is going to happen if somebody doesn't do something about it. So and I know that in each of your places you're talking about this, what's going to be happening?
Well, we discussed this about 2 weeks ago in our laboratory. What will be the effect? I mean, we have a plan, in terms of the immediate problem in the lab, but one of the things that I'm seeing is if we are a small laboratories working on neglected diseases right now at the Institute, with this cut, it's going to be our representation is going to be much lower. Then the impact of our contribution, at least for the view of the National Institute of Health, to work on neglected diseases, it will be compromised severely.
Well, I think one impact at the university level is the loss of funding for graduate students. I think across the country, one of the first things that are cut is the number of admissions to graduate school because there aren't funds in the researchers' laboratories to support those students. And those are kind of the low-hanging fruit to cut without having as much impact in the near term on the research program. The impact in the long term is tremendous.
Sue, anything additional to add from CDC?
I think it's important to add that it isn't just at the federal or national level that economic downturn has impacted public health, but also at the state health department level, that our states are dealing with drastically reduced budgets for public health and have had to let staff go, curtail programs. And so much of what we do around public health efforts in the U.S. is coming out of the states. So when the states hurt, we all hurt.
Could I just respond quickly to Peter's very important point? You're absolutely right, Peter. If it hits Colonia in South Texas, it got a very different impact than if it hits Reston, Virginia. And I refer to the famous Reston virus that came to the area of the Capitol Hill in Reston, Virginia, and environments in 1990. And it turned out that it wasn't even a human pathogen, and yet because it was a quasi primate pathogen, it caused all sorts of things to happen on Capitol Hill. And so there's no doubt that it's not a matter of just hitting our shores, but it is a matter of hitting our shores where there are enough of voices that can be raised to make an issue out of it and to be advocates. I want to say something, though, about the current, also to comment about the current sequestration and situation. When you work a lot abroad, it's amazing what you learn to do without the level of funding that somehow we think we have to have here in the United States. And I mean, I would love to see the NIH and CDC budgets doubled again and all those good things. But I think one of the things we have to respond to is the reality of how can we do things in a more efficient, more effective way, more collaborative way that maybe costs a little less. and yet can get the job done. And here's an example of, for these diseases, where I think there are many places that could work with not a huge budget, but, and I'm just thinking about our area in South Texas where I can see a number of opportunities to set up a fairly simple and straightforward kind of study to try to do what we need, and that is to show whether these diseases, what is their impact on the human population. So I think this is an opportunity, maybe forced on us, but to learn how to do things in a different way and perhaps a little more efficiently. And we have lived in some pretty high times when the NIH budget was doubled and we thought the NSF budget was going to be doubled. But I think we also have to step back and say, how do we do things differently?
Yes, in the middle there.
Hello, my name is Teresa Feria from the University of Texas Pan American. I'm coming from the south of Texas where we have the colonias, and I want to say it's an excellent opportunity for me to be here to hear all what you are saying. We are experiencing there the Chagas, not in dogs, in humans. We don't know too much about it. We are starting research. We need money to do research. And when you talk about these opportunities, one of the things I'm thinking is training. If you go to train people in other places, we would like to have that training also. My university is not a research university. We are mostly undergraduate students in the university. However, we have the kissing bug, we have the sandflies, we have the neotoma species, we have everything there. We have the disease, we have the needs, and I'm very lucky now myself. I'm starting to work with Dr. Valenzuela as my mentor and starting to talk to other people here, but I think we don't have that much money, but in local places, as you are doing in other countries, that is important. Now I'm receiving the training. Well, hopefully I'm going to get that, but getting the funds is not something easy. Right. And that's, but in addition, I have just two questions.
Make it one.
One question very quickly. About Chagas, you didn't mention, but I have seen this in literature, that infected food also can be, can transmit Chagas.
Yeah, there have been several outbreaks associated with foodborne Trypanosoma cruzi from Latin America. They are situations where the fruit that was taken from essentially the jungle, especially palm fruit, collected, brought to a roadside restaurant, and pressed into a fresh juice. So with the fruit probably came triatamines that were in the trees, and so the food was contaminated. And people who drank that juice became infected. And it looks like that route of transmission may actually lead to more severe acute disease, probably a dose-related effect. Is that a concern in other places? Well, again, it's going to depend on, are the triatamines around? Are they contaminating the source of food? Is the food not being processed appropriately before people consume it?
Thank you. With that, we'll move on to the next panel. Thank you all.